to give this talk. So today what I'm going to be talking about is the role of liver in metabolism, especially focusing around diabetes. And now, one of the things that we first need to understand is that non-alcoholic fatty liver disease, it covers an entire spectrum of disease. So in this slide, what you can see is a normal liver, and then you have got non-alcoholic fatty liver. So in this condition, you've got deposit of fat in the liver, causing changes in the histology. And then you have got NASH, which is non-alcoholic steatohepatitis. Then along with the inflammation, you start getting fibrosis. And then you have got cirrhotic NASH, when the liver starts getting damaged and developing cirrhosis. So all this spectrum together is called NAFLD. So how do patients with NAFLD generally present? And this is a very interesting piece to really look at. So they usually found by an unexplained ALT or gamma GT elevation or a fatty liver ultrasound scan. But the recent studies have also shown that there could be a documented reason why they're present. So about 18% of them actually present at a diabetes review, around 15% present on non-specific routine bloods, about 11% present with a hypertensive disease, and about 10% of them generally present with GI symptoms. So to assume that patients with fatty liver disease do not have symptoms is not correct. Some of them do present with symptoms. And some of them present with generalized fatigue or tiredness, and then so on and so forth. So what is important to understand is that some of these patients will present with some kind of symptoms at the time of diagnosis. But there is very little routine screening or case finding done. So what's the annual predicted prevalent case of NAFLD? And here you find a lot of variation, but it's very important to really see this thing in the complete perspective. So in the UK, the prevalence of NAFLD, which is the whole spectrum of the disease, is quite high. It's supposed to be about nearly affecting 20% of the population. Is the maximum. But once you start going to NASH with fibrosis, again, that's supposed to affect about 1 million. NASH with advanced fibrosis, about 350,000. NASH with compensated cirrhosis, the numbers coming down. And finally, the numbers that develop hepatocellular carcinoma or post-liver transplant is very low. So although the prevalence of NAFLD is very high, the number of them that progress to cirrhosis or advanced liver damage is very low. But what is more important is to look that the fibrosis actually predicts mortality in patients with NAFLD. So as the fibrosis increases, the mortality increases. And this is all-cause mortality or mortality from any cause. But if you look at the liver-related mortality, it still remains very low. So how can we diagnose fibrosis? So currently we have got a lot of non-invasive assessment of fibrosis scores, and this includes the AST-ALT ratio, AST to patient ratio index, BART-FIB-4, and NAFLD fibrosis score. And the ELF score actually gives you an idea of how bad the fibrosis really is. Then there is the imaging available. So this includes the TE fibroscan, which is the most common scan that is done. And then we have got the MRE scan, which is being developed. And again, all these scans help to diagnose fibrosis. The risk factors for NAFLD include type 2 diabetes, obesity, dyslipidemia, metabolic syndrome, and polycystic ovary syndrome. And the AASD recommendation in type 2 diabetes will suspect NAFL and NASH. And the EASL, ESD, and ESO actually recommend NAFL screening is recommended. So the current strategies set to you, it's the liver enzymes and followed by screening, followed by MRE scanning. Liver biopsy is because it is quite good because it establishes the diagnosis of NASH. It can assess early fibrosis and determines prognosis and rules out other conditions. It's got quite limitations as there is increased risk of bleeding. There is sampling variability and long interval between serial biopsies, and the cost and the pain it causes to the patient. Now, one of the scores that we tend to use quite commonly, which is now easily available on the internet, where you can enter certain criteria, including the age, AST, LT, platelet count, BMI, albumin, and it tends to give you cutoffs for developing fibrosis, and a FRIP score of F3 to F4 is low probability, and then you have got indeterminate and then high probability. So in the first part of my talk, I just went through things about trying to explain what is NAFLD, the whole spectrum of the NAFLD, starting from non-alcoholic fatty liver to NASH, to cirrhosis, to hepatocellular carcinomas, how it can be diagnosed based on non-invasive and invasive methods, and the impact it has on the mortality and morbidity. And the second part of my talk, in the next 7-8 minutes, I'll talk about the treatments and what current treatments are really available. So approaches for current treatment available can be targeted into four groups. One is to control obesity, because weight loss, either by diet, exercise, or bariatric surgery, is known to work. The second one is to reduce cardiovascular risk, and this is by treating metabolic syndrome, hypertension, and dyslipidemia. The other one is to reduce the risk of hepatocellular carcinomas. This could be done by using drugs like metformin or simvastatin. And the last one is to target the NASH itself. Currently, there are very few treatments available. Recently, semaglutide data from SEMA-NASH study has become available, which looks interesting. But the other data or trials that have shown includes vitamin E, pioglitazone, and liraglutide. So when it comes to weight loss, it depends upon the amount of weight loss. So if you are able to achieve greater than 10% weight loss, it causes fibrosis regression by 45%, between 64 to 90%, and greater than 5% causes decreasing of the ballooning inflammation and improvement in 41 to 100% patient. And if it's greater than 3%, there is steatosis improvement. And this we can actually see in this slide, that as the liver fat decreases, the insulin sensitivity tends to increase. And this has been shown in a number of studies, including the lean study, which shows a direct correlation between the decrease in the fat in the liver and the insulin sensitivity. You all are probably aware of all these drugs that have been used, but the only one that's been studied in NASH is liraglutide, a dose of 1.8 milligrams, and which has shown to decrease weight. As I said to you, all this that has been looked in very, very, very small studies. And this is the study was been talking about the SEMA-NASH studies. And this has shown, now the results are available, quite a good resolution of NASH in patients. Obesity per se does work because it causes weight loss, and depending upon the type of surgery that is used, the weight loss is much higher, and that tends to benefit the NAFL patients. And this is from the veteran study with obesity, saying that the greater the weight loss, the greater the benefit for NAFL. And this is a study that actually shows that the biopsy validated NASH with greater than one comorbidity for 5 years, and it shows that the resolution or the histological improvement that is seen with bariatric surgery is quite improved, is quite impressive. So, summary of weight loss in NAFL is counsel all patients on healthy lifestyle with diet, exercise, and lifestyle. To achieve and maintain weight loss, consider pharmacological approaches in overweight individuals greater than 27. Diet and exercise will get a weight loss between 5 to 8%, pharmacological approaches between 8 to 10%, and bariatric surgery between 10 to 90%. Normal liver, you target related to insulin resistance or lipid metabolism, and these are the drugs available. Once you develop NAFL, your target relates to lipotoxicity and oxidative stress. Once you develop steatohepatitis, the target relates to inflammation and immune activation. And once you develop NASH, the targets relate to cell death, apoptosis, and necrosis. And once you develop cirrhosis, now you target the fibrogenosis and collagen numbers. And these are some of the drugs that have been studied. Pioglitazone has been the most, and it does show an improvement of NASH, but currently it's not been used that much because of weight gain. Vitamin E may be used in non-diabetic adults with both proven NASH, and I have talked to you about things. These drugs are generally safe, and with pioglitazone, as taxologists, we have used these drugs quite a lot, and they have shown to increase the risk of bladder cancer or heart failure in some patients. The emerging treatment options would include drugs that can be used for NASH resolution and drugs that can be used for fibrosis improvement. With the NASH trials, I'm not going to go in it, but this one's there are a number of drugs that are being tried, which usually tend to target the NASH fibrosis, but none of them are currently licensed. And there are a number of other agents also that are being used in phase 3 and phase 4 studies, basically looking at NASH compensations. In terms of the diabetes drugs, there is some evidence with drugs like empagliflozin showing minor benefit of these agents. And then there are a whole host of anti-diabetic agents that have been used in NAFLD. And I just mentioned about the SEMA-NASH study, which has been reported in an abstract and has shown good results in terms of resolutions. I think, and this is just to say, in advanced hepatic dysfunction, most of the drugs can be used, but once you develop Child-Pugh A or Child-Pugh B, then the number of drugs that can be used really goes down, and the only two drugs that don't have any side effects are Finally, in management of obesity, diabetes, and NAFO, we need a multidisciplinary approach that includes a hepatologist, endocrinologist, nutritionalist. Managing cardiovascular risk reduction is essential, and screening and treating other comorbidities is very important. Thank you.